I'm going to be reviewing a lot of numbers in this talk, specifically doses at which our medications work best. Rather than writing down all 50 doses, you can find the slides here at chrisaikenmd.com, high-dose psychiatry. This talk is not about new treatments in psychiatry, but rather about what we've done in psychiatry when we get desperate and don't have answers, and how that turns out. What we often do is raise the dose very high. And it turns out very well, at least to our own eye. These are reports from the 1970s when, only 70% of people with schizophrenia respond to antipsychotics. So that left us with many patients who were not responding, and people were desperate to get answers, so they raised the dose very high. I'm talking 10 to 20 times the normal dose of an antipsychotic like haloperidol. And let's all keep this in mind of what the observers of the day saw when they raised the dose to haloperidol 200 milligrams, that these patients have nothing to lose and much to gain by this strategy, and that there is virtually no extrapyramidal side effects. Now, this is how the eye can deceive you. So we often make changes in practice, patients respond, we interpret their response as improvement on the medication when it may be something else entirely. This practice caused terrible rates of tardive dyskinesia, prompting, in fact, the discovery of clozapine, which was brought to us because it did not cause tardive dyskinesia. We later learned that it works in many of these 30% who do not respond to antipsychotics. This practice of high-dose antipsychotics went on for many years before it was recognized that it does not do any good and only does harm. That mostly came to an end with this paper by Ross Baldassarrini from Harvard that looked at 33 randomized trials and concluded there was no benefit with high-dose antipsychotics. Moving forward to present day, this is the most recent analysis showing that the antipsychotic response peaks at around 4 milligrams of risperidone equivalents. And if we break that up into each antipsychotic, which you see here, you see that flattening of the dose-response curve where it doesn't get better as you go higher. But take a look down at the bottom. Don't those look like they are getting better as you go higher? So there is maybe some potential here. Let's narrow in on those more. And this paliperidone as well. So some of those turn out to be false leads due to 1 or 2 studies or not having real differences when they're compared. But over here, and I'll highlight it here, these antipsychotics do not appear to plateau. So we have a signal from all of this data that maybe you can go higher in iloperidone, lorazepam, olanzapine, and paliperidone in schizophrenia. But that is just a signal, not enough to warrant widespread use, except for one of these, which I will show you now, because olanzapine may be the only antipsychotic with proof to work in higher doses. That comes from 4 randomized controlled trials where it was compared to switching to clozapine in treatment-resistant schizophrenia. And in most of those trials, it did work. So if your patient with schizophrenia is not responding to medications, you do have a justification to go all the way up to 50 in olanzapine to see if you get a response. With the others, probably not. Let's turn to antidepressants, where the entire field was misled by an early finding. That finding is true, and it applies to tricyclics. Tricyclic antidepressants, we've long known, have a dose-dependent response. You see that the response gets better as the dose goes higher, with a pretty significant effect size for each 100 milligram equivalents. So it was assumed when the other antidepressants came out that you would also see better responses at higher doses, and you don't. Here's the dose response curve from the best meta-analysis for SSRIs, and you see they tend to flatten around the equivalent of fluoxetine 20 to 30 milligrams a day. But what happens on the other side? The side effects are continuing to rise up as you go higher in the dose. Side effects like sleep disruption, fatigue, sexual dysfunction, apathy, side effects that look like depression. We see a similar thing with venlafaxine peaking between 150 and the side effects going higher. With mirtazapine peaking around 30 milligrams and then the benefits going down after that and the side effects going higher. With our newer one, vortioxetine, we see a similar plateau between 10 and 15 and the side effects going higher. Looking into this by class, you notice that all of these curves are flat except one. The NRIs, norepinephrine reuptake inhibitors. Remember, the tricyclics, which have that effect, also had a dose response. So if your antidepressant has a strong norepinephrine component, you might see more improvement as the dose goes higher, and most of that data was from a medication we do not use in the US, unfortunately, but I understand you have here in Turkey, reboxetine at the bottom, where the response keeps going up to 10 milligrams a day. You see clomipramine, a tricyclic at the top, also has a dose response. Now, another question is, should you raise the dose or just wait it out? Clearly, if you are raising the dose, you're also waiting it out. You're giving it more time at a higher dose. So let's look at what happens in those choices. With the SSRIs and mirtazapine, there is no difference between raising the dose and waiting it out, so it doesn't work. But with venlafaxine, yes, again, only in that dose range that I showed you is most effective, 75 to 150. This is for your reference, all of the optimal doses from these curves, and they're on that website. You see that nifazodone and trazodone, I put a question mark because we don't actually have comparative data. But I will say, if you use trazodone, you should raise the dose slowly in depression, because you raise it too quickly, it can produce a metabolite that has depressive effects, MCPP. And there are some studies where it works better if it's raised slowly. Missing from here are the MAOIs, which also lack dose response data, but there are case reports of very high dose MAOIs like tranylcypromine, 140 milligrams, working in very treatment-resistant patients, so that's a possibility. Moving on to mood stabilizers, this is just to update everyone on the latest serum guidelines for lithium in bipolar and in depression, unipolar depression, which is 0.6 to 0.8 is where the guidelines are coming in, and a little higher for mania. But if your patient is older, they're going to absorb more of that lithium into the brain, so they don't need as much in their body. You can lower the dose about 30%, lower the serum level if your patient is older. And some of our most exciting new data is that in several very large studies, they found no damage to the kidneys if the serum level was kept below 0.8. So here's a situation where keeping the dose in the lower range can be very beneficial to the patient. Lamotrigine, we have trials comparing 400 to 200. 400 work no better. So 200 is the max for mood benefits in lamotrigine. And I do find patients tend to get worse cognition if the dose goes too high on that one. There are exceptions, like women on birth control pills or hormone replacement therapy may need a higher dose due to drug interactions. Lorazepam, which we use for bipolar depression. Here are two slides, and this is really for people in the audience who want to hear about the technical details of studies, or go home and look up what I'm saying and see that everything I've said is wrong. You may find that. No, this is why. It has to do with flexible dose versus fixed dose studies. Everything I've said applies to fixed dose studies where they're comparing two doses and not changing them during the trial. Now, in this slide, the first one, going down is better. So in the first one, looking at all flexible dose trials, you see that it looks like lorazepam gets better as the dose goes higher. But when you look at fixed dose trials, you don't see that. You see that it plateaus around 20 to 60 milligrams. Now, why is this? Because in a randomized trial, when you're changing the dose flexibly during the trial, you're introducing a new variable that's not randomized. If the patient is aware of this, perhaps through side effects, then they're going to feel better because their dose has been raised and they feel their needs have been met. It's a placebo effect. Or you're narrowing it down to just the treatment-resistant cases where you raise the dose to a different population. So what you tend to see in these studies, including antidepressants like SSRIs, if you look at flexibly dosed trials, you do see a dose response. If you look at fixed dose trials, which is a more conservative way to look at it, you don't see a dose response. Here is another one with antipsychotics and depression showing for our newest antipsychotics, the benefits in depression level off after a certain level. 5.5 for aripiprazole, 1.6 for brexpiprazole, and 1.5 for cariprazine. You also see that aripiprazole is a bit bigger, right? Its curve is higher. This is a consistent finding in antipsychotics that aripiprazole has a slightly bigger effect than the others in depression. So many are using aripiprazole first line among the antipsychotics for depression. It has more studies in treatment-resistant cases and a bigger effect size. Not markedly bigger, but a little bigger. Quetiapine, I've just given you for your reference different dosages. Since this is a drug that's effective in many different conditions, it almost got FDA approved for generalized anxiety disorder, in fact. And it's the only antipsychotic that treats major depression as monotherapy by itself. It didn't get approved for that, but the studies looked very good. So very different doses for that one, depending on the condition. I'll wrap up with stimulants. And here you all will appreciate how good it is that amphetamines are not used in Turkey. This paper came out about a year ago in JAMA Psychiatry, and it's really a landmark trial showing us the dose-response curve for adults with ADHD, starting with methylphenidate. And what you see is not much better beyond 60 milligrams a day of methylphenidate, but on the other side, the side effects are increasing beyond 60 milligrams a day of methylphenidate in adults. So they found the sweet spot here for methylphenidate. Now let's turn to amphetamines, Adderall, Vyvanse. We see the response getting no better beyond 35 to 40, and the side effects shooting way higher. A little concerning, and I'll show you more concerning data in a minute. Here is what happens when you go really high on stimulants. Remember, these are medicines that flood the brain with dopamine in higher dosages. This comes from a study of narcolepsy where they weren't responding, so they went real high, like 2 to 3 times more than the usual dose, 120 milligrams a day. And look at the rates of psychiatric problems in those patients who did not have psychiatric disorder, and the stimulants were driving them to these conditions. Last year from Harvard's Mass General Hospital, we saw this large study where there is a 3 to 5 times increase in psychosis and mania in people who were prescribed amphetamines and admitted to the hospital. They saw no increase with methylphenidate. So in America, we're seeing lots of problems with amphetamines. They're being prescribed in large amounts, way much. So much that the pharmacies have run out of them. It's a continuous problem I hope you're not dealing with here. Methylphenidate overall much safer, And the reason may have to do with neurotoxicity. We see more studies showing neurotoxicity with amphetamines than methylphenidate. Amphetamines squeeze out dopamine, so you're pushing it out like a tube, flooding the brain with more dopamine. Dopamine is neuroinflammatory, neurotoxic, and after a few weeks on that, the brain gets depleted of dopamine. This is particularly true in older patients. I've talked to you about lithium being absorbed in the brain more. We don't have as much data on stimulants, but it looks like older adults absorb at least more amphetamine, and possibly methylphenidate is more absorbed into the brain. We have no studies of stimulants in people older than age 50. But there are 2 chart reviews I could find, and they tended to use lower dosages in the older adults. We're talking methylphenidate 5 to 25 milligrams a day, the lower range, which I think is good practice. So high-dose stimulants, think twice before going above these ranges. All right, I'll stop and take questions.